Welcome to Hersing University NU 640 Introduction to Women's Health Across the Lifespan. This video will review Chapter 22 and discuss Chapter 23 from your Alexander and colleagues textbook, as well as Chapter 14 from your Sarkio and Secor text. This discussion will serve as a brief overview of the material. Therefore, I would like to ask that you please read the chapters for additional and required information. I also highly recommend to review all other required and supplemental resources. To note, this presentation will be given by Drs. Alicia Sutton and Lauren Ashton.
I would like to begin with a brief recap of Chapter 22 from Unit 8. Ideally, a woman planning pregnancy should have a medical evaluation before conception. This allows you the opportunity to determine any risk factors that will complicate the pregnancy. However, many women do not, as nearly 1/2 of all pregnancies are unintended. Therefore, ACOG, the CDC, and many other organizations recommend that preconception care needs to be considered an integral part of primary care for any woman of a reproductive age. So many of these factors, as you know, we've discussed it since week 1 of this course. You need to think of prenatal care as an extension of primary care principles. But you now must be considering how these factors could impact a potential pregnancy. Common issues in preconception care include identifying genetic risks, achieving a healthy body weight, screening and treatment for unhealthy behaviors or infectious diseases, updating appropriate immunizations, and reviewing medications for possible teratogenic effects. If a mother does not receive preconception care, then you, the provider, will need to complete the anticipatory guidance during your prenatal visit. Therefore, I feel that it is good to review some of these topics here. In regards to nutrition, women should not attempt weight loss during pregnancy, and the recommended daily allowances are adjusted based on their current size and weight. So you're actually going to figure their BMI and take into consideration when you're discussing nutritional needs with your patients. A woman will only need to increase her caloric intake by about 300 calories per day. During lactation, she can expect to burn about 500 calories per day, so you will also want to take that into consideration. Calcium should be 1,200 to 1,500 milligrams per day. Folic acid is needed to prevent neural tube defects, and ideally your patient should be taking 3 months prior to conception. Iron is best obtained from the diet, but you can give elemental iron of about 30 milligrams per day. You will also want to encourage increasing fiber to avoid constipation, increasing fluid intake to at least 8 to 10 glasses of water per day. In regards to travel, we've already discussed that women are at an increased risk of developing DVTs, so you want to encourage your patients to avoid prolonged setting, to stay well hydrated, and basically be up and moving as much as possible. Your patients can fly, but typically not after 36 weeks, and of course you want to encourage your patients to always wear their seatbelt. There's not any exceptions for work, except for your patients to avoid heavy lifting or exposure to hazardous chemicals. You may actually have to provide them with a work release. There is no restriction in regards to sexual activity unless there is a rupture of membranes or they have a complete placenta previa. Some also will recommend pelvic rest for those that are at an increased risk of preterm labor. The rationale for this is because semen is a prostaglandin that can cause uterine contractions. And of course, you will always want to talk with your patients about warning signs that will require them to notify your office immediately, such as vaginal bleeding, abdominal pain, or pelvic pressure, nausea and vomiting for 24 hours in which they are unable to keep any fluid or food down, any sign of infection such as fever or a rash, any abnormal vaginal discharge, and any change in fetal activity after quickening. Of course, you will want to also review your patient's immunization records and ensure that they receive updates on any vaccinations they are eligible for. If you recall from Unit 3, when considering appropriate vaccination schedules for women, it's important to note that measles, mumps, and rubella, or MMR, and varicella vaccines are contraindicated for women who are pregnant. I do want to spend a moment and review titers with you. Titers for rubella are standard of care with each pregnancy and assess a pregnant woman's immunity status. If she has a titer of greater than 1 to 9, then she is immune. Now with varicella, you can verify immunity by lab testing, proof of previous vaccination, or healthcare provider confirmation of infection. If you do conduct the diagnostic, your patient is immune if she has a titer of greater than 1 to 8. And you may or may not get the rubeola. If you do, and they have the IgG, G being gone, or the antibody is gone, then your patients are good. Moving on to teratogens. As Chapter 22 explained, a teratogen is a toxin, drug, or biologic agent that causes a harmful effect to a fetus. Therefore, you should be inquiring about and educating patients regarding these. Smoking during pregnancy is associated with an increased risk of intrauterine growth restriction, placenta previa, placenta abruption, preterm birth, low birth weight, and perinatal mortality. Therefore, pregnant women should all be encouraged to discontinue smoking. And illegal substance and alcohol use should also be avoided, as there's no level or time of exposure considered to be safe when it comes to alcohol or drug use during pregnancy. The characteristic period for this to occur is between day 7 and day 56 following the last menstrual period, when the organs are developing.
I pulled this chart from Chapter 22 on page 400. It offers you a visual guide of critical points in the development of a fetus. If you recall from patho, placental implantation begins about 5 days after fertilization and is complete by days 9 or 10, before most women know they're even pregnant. The red bars illustrate the critical periods of structural development for many organs, and the yellow bars indicate the periods of functional development.
Teratogen and phytotoxins are dependent on genotype susceptibility, timing of exposure, specific mechanism, manifestation, and the agent and dose effect. So an example would be for a teratogen to exert its effect, it must be taken at the point in the pregnancy when the affected organ system is developing. As a result of this evidence-based research, we now have pregnancy risk categories by the FDA. This is a very big item for you to be aware of. Basically, category A is appropriate or excellent. These medications have not shown an increased risk. Category B is the best. This is your next best choice. Category C, I always say, is equal to caution. This is where the risk versus benefits come into play. And category D is danger, and category X, cross off your list and absolutely do not use.